Hi everyone, my name is Leah Khawaja, and today I will be addressing how racial inequality pervades the healthcare system and how this issue has been exemplified and exacerbated by the ongoing COVID-19 pandemic. In an article written by Harry Kretschmer from the World Economic Forum, he writes that on a global scale, the pandemic is harming racialized populations the worst, most emphatically with harming BIPOC communities, according to the CDC. However, this is nothing new. Pandemic aside, if we look at health issues such as HIV/AIDS, cancer, complications in prenatal care, complications in amputations, Black, Indigenous, and people of color, or BIPOC for short, are one, more likely to be affected, and two, more significantly, less likely to receive proper treatment. And these statistics show hospitalization and death by race/ethnicity from the CDC. For instance, in a 2021 study done by the Human Rights Watch, almost 4,300 women in the United States died of cervical cancer, with disproportionately higher rates in Black women. As Enrique Daniel states, cervical deaths aren't just a tragedy, they reveal systematic exclusion from life-saving healthcare and information. Kretschmer cites implicit bias as a main factor, which in context is when doctors are subconsciously prejudiced and project negative stereotypes onto BIPOC patients. As a result, interactions between the professional and the patient are unpleasant. As Assistant Professor Roberta Timothy at the University of Toronto Centre for Pandemics points out, many people of color are distrustful and already keep the healthcare at an arm's length, citing racial biases as their motivation for doing so. However, given that we are living in an ongoing pandemic, this poses grave consequences for BIPOC individuals, as racialized peoples will seek for help during emergencies, but by the time that they finally choose to do so, it is too late. As Joseph Amen and Margaret Worth point out, international human rights law guarantees that everyone has the right to the highest attainable standard of health, which then obligates governments to take preventative measures to ensure that people are protected. Further, in Article 25 of the Universal Declaration of Human Rights, everyone has the right to a standard of living adequate for the health and well-being of oneself and of one's family, including medical care, and the right to security in the event of sickness or other lack of livelihood in circumstances beyond one's control. As simple as this should be, unfortunately, it has become increasingly clear that historical social inequalities permeate the issues of the pandemic, leaving racialized people at an increased exposure detrimental to their physical health. In a systematic literature review on public health literature, it is noted that while many factors shape the health and well-being of individuals, institutionalized racism plays a significant role in generating inequities such as unjust health outcomes. Thus, we must investigate the historical systemic processes that have shaped these institutions and have allowed for such inequalities to manifest. For instance, in the early 20th century, as Kretschmer notes, Black people specifically were targeted for medical experimentation, ergo forming the foundation for systemic medical racism. To demonstrate, in 1951, Henrietta Lacks was a Black woman diagnosed with cervical cancer and eventually died because of it. However, her cells lived on. This led to doctors culturing, meaning mass replicating them, and became leeway for medical breakthroughs such as the development of the polio vaccine and IVF. Yet her cells were taken without her and her family's consent, thus in part forming the groundwork for medical racism to occur as we know today. Further, Gamlin, Gibbon, and Calistani write that colonialism continues to pose consequences for the health of minority populations, as demonstrated by their example of the COVID-19 pandemic and how ethnic populations suffer the most in the UK, and similar circumstances exhibited in the US and Canada similarly. They argue that there is a long list of evidence in health disparities between minorities and white people, especially with the pandemic, and how this continues to thrive through neocolonial racism. They describe this as the afterlife of colonialism and colonialism's permanence, solidified by the institutional framework of medical systems exploiting minorities. Now that the impact of medical racism and COVID-19 has been identified and described in greater detail, we can identify some of the mechanisms put in place to address the issue. Earlier in the spring of the pandemic, the Ontario government deliberately refused to collect race-based data and took a color-blind approach method instead. Unpleased by this decision, in a letter to Premier Doug Ford, 192 Canadian organizations demanded the Ontario government to collect race and socio-demographic data amid the pandemic, poignantly stating, "We cannot address what we can't measure." Fortunately, by June, there was a new mandate to collect this said data when checking who has been infected by the virus. In an article from Dalhousie University, Dr. Omisor Dryden discusses the importance of collecting race-based health data. As she points out, the collection of race-based data is important in order to shed light on the gaps in the healthcare system. Looking at the Ontario Human Rights Code, race-based data in the context of racial discrimination could be used as a necessary tool to assess whether human rights are being infringed upon and corrective measures to mitigate and respond to the issue. On a national level, this CBC article delineates that a nationwide research project started by Dr. Roberta Timothy at U of T would be carried out to observe the impact of the pandemic on racialized peoples in addition to inspecting the existing racial biases in the healthcare system. Nonetheless, we should look at this critically and evaluate how effective this approach has been in addressing the issue. In this qualitative study looking at race-based collection methods in Canada, Ahmed et al. Acknowledged that racial inequality has caused BIPOC communities to be disproportionately affected by the pandemic and agree that race-based data is needed. However, they also acknowledge that other factors must be considered, such as inequitable distribution of resources, like government funding, housing, social support, and food insecurity. Additionally, many BIPOC communities are more widely affected by chronic conditions such as HIV, diabetes, and food insecurity, which worsens the impact of the virus upon contraction. To put it simply, if we personify the virus, we know that it does not discriminate against who it infects on a racial basis. But without the conditions of adequate distribution of resources, there is a greater susceptibility of contracting the virus, which is then compounded by evident racial biases upon professional and patient interaction. Ahmed et al. Suggest that in addition to the albeit long overdue implementation of collecting race-based data, the government should have also carried out preventative measures such as additional funding and safety resources like medical masks and sanitizer to marginalized BIPOC communities beforehand. If we look at the reality of how the pandemic has been handled, especially in Ontario, if race-based data collection was done earlier in tandem with additional aforementioned preventative measures, the intersectionality between race, income disparity, and resource availability would have been more apparent, and thus the issue of racial biases in the health system and the virus's impact could have been dealt with in a more effective manner to make its reparations to BIPOC individuals who have been failed by systems such as the healthcare sector consistently. These are all the references used for this presentation, and I thank you for listening to it.